Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of testicular cancer. Dr. Travis Brown, for some reason I find this topic more sensitive than most.
Excellent. I suspect you would. I suspect most men would. We are discussing testicular cancer. Look, it's an important topic. Fortunately, it's a rare disease, but it is one that is surprisingly, it's actually it's a modern medical achievement. Testicular cancer is one of our best treated conditions. And it's an area, despite men's bravado, we actually don't talk about a lot. And I'm not quite sure why. It's like people, men are normally very apt at being able to discuss their genitals and everything like that. But when it comes to a serious topic, it sort of gets a little bit of embarrassment or...
Gee, I don't know who you mix with.
Well, and here's the thing about testicular cancer is that there's actually quite a number. We'll come to the end. I've got a challenge for you. Just in your marketing kind of way. How could we get a slogan for the next testicular cancer awareness program? But look, we're looking at this as it is a medical achievement. Overall success rate of treatment is over 95% in general.
That is rare, isn't it?
Very rare. And even, 5-year survival. Now, the most advanced testicular cancer you can get is stage 3. So we don't actually have a stage 4, which is interesting. We'll have a further discussion with our guests about that. But the survival rate for patients, even at stage 3, so the highest metastatic disease involving other organs, is still 70 to 75% survival rate, 5-year survival. So that is incredible. And look, if you look at the ancient sources, it's actually difficult to identify, even though the superficial nature of testicular cancer, I initially thought, there'll be quite a lot of literature about this, but it's not. And that's because there is difficulty in distinguishing in ancient times about testicular swellings and testicular cancer. And so scrotal swellings were referred to quite a bit. You've got the Edwin papyrus that actually talks about scrotal swelling. So this is ancient Egyptian. But they actually categorize scrotal swellings as soft versus hard. Now, hard is typically more cancerous. And so they actually mentioned that if it was a firm mass, then this was actually incurable.
What sort of papyrus is this? Have we actually found a medical...
Yeah, Edward Smith papyrus. And so this is where they talk about their medical kind of treatments and stuff. A lot of it is about war. A lot about healing war wounds and stuff. And so this is part of their fantastic physician medical knowledge that I always love. I love the Egyptians. And look... That's kind of where it looks from. And for the most part, testicular cancer was pretty much universally fatal. And this is because we didn't have any treatments. You get to the 19th century, and yes, they did have surgery for this. But again, surgery was pre-anesthetic. It also could be lots of bleeding. As well as lots of post-operative infection. And so mortality rates were very large, very significant. And you look, again, people died either from the treatment or the actual disease itself. And so there have been some famous instances of people having testicular cancer. There was Prince Christian of Denmark. He was about 40 years old when he was diagnosed in the 1980s. There's in the 1990s, Lance Armstrong. So he was diagnosed at 25 years of age. His history is quite interesting because he presented with quite a bit of pain and swelling in the testis. He continued to ride even to the point where he couldn't sit on the bike. He ignored his symptoms for several months. He got to the point where his testicle was about the size of a good-sized lemon. And so still ignored it. But when he started getting symptoms, he was having headaches. He was having blurry vision. The symptom that got him to the doctor, though, was he was coughing up blood. And so he ended up...
Everybody has their level, don't they?
It is incredible. Again, elite athletes sometimes will go beyond, what anyone else would do, and they just deal with pain. And he was just dealing with that pain. Now he went to the doctor with these symptoms. He actually had surgery the next day, and he ended up having metastatic disease going to his brain and his lungs. Oncologists at the time gave him about a 65 to 85% chance of survival, but he was also an amazing success story of treatment. Probably not early identification though, but one of those things that he has gotten that message out there about testicular cancer. And so it begs the question, why is testicular cancer so unusual? And it's so unusual because it hits young men. It's very aggressive, it can grow very fast, and you can have metastatic spread. Now, before the 1970s, this metastatic testicular cancer had survival rates of about 5 to 10%. Now, what happened to change this? It was actually an accidental discovery that changed this.
Another accidental discovery in medicine.
Yeah. Yes. It's Dr. Barnett Rosenberg, who was a biophysicist in Michigan State University, and he was studying cell division in bacteria. And what he wanted was he got a solution of E. coli and he put platinum electrodes in it with an electrical current. And what he thought, his theory was, well, the bacteria with that electrical current will grow abnormally or they'll collect around the platinum electrodes and grow that way. Neither actually happened. In fact, what happened was the E. coli grew larger, but it couldn't divide. And he ended up repeating the experiment, but without electricity, not putting any current, and the same result happened. He used then different electrodes, and the E. coli grew and was able to divide. So these platinum electrodes partially dissolved in the solution, and it created this compound. And this compound cross-linked the DNA, and it impaired the ability of the bacteria to divide. Now, they called it cisplatin, and this turned out to be a chemotherapy drug that stopped cancer cells dividing.
Our intention was to study physics. We stumbled onto a drug that saved thousands of lives.
So in the 1970s, Dr. Lawrence Einhorn, who was an oncologist at Indiana University, trialed a chemotherapy regime. This was cisplatin, so that accidentally discovered drug, vinblastine and bleomycin. And so this was a chemotherapy regime. It was trying to actually inhibit the growth of cancer. The cure rates went up to like 80 to 90%. And so the amazing thing, as I mentioned about testicular cancer, is it's really susceptible to chemotherapy. DNA, that is these are cells that are very early, meaning that they can actually differentiate into all kinds of different cells. And so when they're actually dividing, they can actually differentiate into anything, but the DNA repair mechanism is not either mature or is actually functionally impaired, because you need that kind of flexibility to produce like a skin cell or a liver cell or a nerve cell. And so if something's trying to repair, what are you trying to repair it before? And so it is actually really sensitive to chemotherapy. So in the last 50 to 55 years, we've refined treatments. We've learned more about the different types of cancer. We have learned about the regimes and what works. Some patients may not even need treatment other than surgery. And so it's removing it. And this is understanding the type of tumours we're dealing with. As with most cancers, early detection is key. We're wanting to identify these as early as possible to get the best possible outcomes. Again, these are young men often. Sometimes they can be a bit older, but still very manageable if detected early. And so there's been actually, a number of, health awareness campaigns. Again, it's trying to get people to check, or men to check their testes. Call it what you will. You've got quite a number of names of terms, balls, nuts, whatever like that. And so it's trying to reduce the embarrassment. It's talking to young men about doing this, checking themselves, raising awareness. And so there's been a whole bunch of slogans that have come out. Some of the ones from Australia is check your balls. Another one is check your nuts. One is, how's your pear hanging with a, fruit pear next to it? Yeah.
Right.
So all kind of happening. In the UK, they have others. It's sort of, it's in the bag. There's an awareness campaign from the Oddballs Foundation. Steve, any marketing light bulbs popping into your head at all?
Well, look, there is a certain vein in which, so to speak, in which we draw ideas from. I was thinking from a sporting perspective, a little play on a common saying would be, keep your eyes on the balls.
Yeah, that's right.
And I think that in some sort of sport saturated poster might.
Yeah, probably. I was thinking like, using, it's a little bit old now. It's probably be, even old for my, check Deez nuts. Just one of those things, but it's actually just trying to get the message out there as to what's, getting people to check, getting people to actually discuss it a little bit more, and then raise awareness of it. And then if someone does have something that's wrong,
yes,
to actually talk to a doctor or someone about it.
There was a mates don't let mates drink and drive ad many years ago. I don't suppose you want to suggest. Give a mate a hand. Dr. Nari Ahmadi is a urologist and urological cancer surgeon with a subspecialisation in robotic and laparoscopic urology based in Sydney, Australia. Dr. Ahmadi studied at the University of New South Wales, the University of Sydney, and the Institute of Urology at the University of Southern California in Los Angeles. He's also trained alongside world-renowned leader in urology, Professor Inderbir Gill. And he's the coordinator of urological oncology cancer research at Chris O'Brien Lifehouse. Nari's our guest here on This Medical Life podcast. Nari, welcome.
Oh, thank you so much for having me. It's an absolute pleasure.
Let's get underway by defining something. Just how common is testicular cancer?
Yeah, so testicular cancer, when you look at it in all the cancers, is not one of the very common ones. But when you look at the specific target group, in the youngest men, it's the most common cancer in young men. So when you look at it overall population, obviously older people get more cancers with breast cancers and prostate cancers and other things. But when you look at the target group of people who actually get testicular cancer, which is the young guys between 18 to 40, it's the most common cancer by far, excluding the skin cancers. So overall risk is about 1% of people do get testicular cancer. It can happen to men at any age, but it's very common in the teenage years and early adulthood.
What's the most common presentation for patients with testicular cancer?
Yeah, so the most common presentation is usually feeling a little lump in the scrotum and the testicle. But also some people feel pain in the testes. Very rarely people present with back pain and other symptoms. That's symptoms when cancer has spread elsewhere to the retroperitoneum, abdomen, or chest. And those are late signals of presentation. But quite often it's usually a lump that they feel or something abnormal, or growth in the testicle, or pain.
Is it possible that someone could live their life without knowing they have this? Or would the symptoms dramatically increase at some point where it's impossible to ignore?
Yeah, one of the good things about testicular cancer is actually a very aggressive cancer most of the times. So it just gets worse and worse. So eventually people present with a symptom and it just gets worse and worse. So initially when it's a lump in the testicle, it's easier to fix. But when it spreads, it becomes much more challenging to fix. So the later they present, the more complex the treatment is. If majority of the testicular cancers are aggressive subtypes, so if they're left untreated, they can kill a patient.
Are there any common or benign mimics of testicular cancer that patients might present and say, I've got a lump, and then be reassured that it's actually benign?
Yeah, quite a lot. In fact, it's more common to get those things than the testicular cancer. There are quite a few different conditions. One of them is called the hydrocele, when there's a swelling of the testicle and there's fluid buildup in the scrotum. Not testicles, sorry, fluid in the scrotum. Some people can have cysts around the tissue around the testicle. There's a tissue called epididymis, and that can grow, have cysts. Then people can have infections and inflammation of that epididymis or infection of the testes. Sometimes people can have injury and there's hematoma and blood clots in the scrotal sac. Or sometimes you can have enlarged veins around the testes called varicocele, which is also a very common thing. So these are usually, all of them are very common. So it's very common to see this kind of a thing. And the main way of differentiating it is the ultrasound. If the ultrasound shows that there's a growth inside the testicle, it's most likely a cancer. If it's anything else outside the testicle, it's most likely not cancer. So that's how we usually tell the difference. That ultrasound is critical for us and our diagnosis.
How useful is pain as a symptom? Is that sort of rule in, rule out, or it doesn't actually matter?
Yeah, the pain can be a helpful thing. Anything that leads you to have that ultrasound, essentially. In our series, when we looked at our testicular cancer patients, maybe about 20-30% of them presented with pain rather than a lump. Sometimes the lump is not big enough to be felt, or it's inside the testicle, it causes firmness and stretching. And so essentially, rarely, it's not always present at pain. The most common presentation is the lump. One of the second or third most presentation is usually pain.
Sorry to harp on this. I'm just trying to work out, because pain in scrotal region, testicular region, could be actually sort of a dull ache all the way through to sharp pain. Is there any way to quantify that pain?
The funny thing is testicles are very sensitive organs, so it's very common to present with testicular pain that's got nothing to do with any cancers. And it's we see this quite often. People present with testicular pain and you do an ultrasound and there's no cancer. So it's just one of the symptoms that may present for testicular, may help you diagnose testicular cancer. But the big one is the lump, when you see a new lump.
The new lump and then ultrasound.
New lump, follow this straight away. So the advice we give is, if you feel a lump in the testicle, straight away see your GP and don't delay it, because these are usually fast growing tumors. So straight away see a medical practitioner, general practitioner, and they usually examine you. They do some blood test and ultrasound. And then that ultrasound will show you if there's a growth inside the testicle or not. If there's a growth inside the testicle, then patients should be very urgently referred to a urologist.
Is size of the lump anything to measure on? Like if someone says it's actually a small lump or anything like that, or larger than a centimeter, is there anything to do with size?
Not hugely. Like the bigger it is, sometimes it's worse. So a lot of times, for example, with seminoma, if it's more than 4 centimeters, it's a negative prognostic feature. So it's a higher chance that it would have spread. But any lump essentially can be associated with testicular cancer of any severity.
Are there any concerning symptoms that raise a red flag to you when you see a patient?
Beside the lump, usually there's a couple of other things that we look for. There's a family history. So if someone has a family history of testicular cancer, their risk goes a little bit higher up. So it goes from 1% to 2%. The big one is risk of undescended, the past history of undescended testes. So a lot of the newborn boys, if the testicle hasn't descended into the scrotum, they call it undescended testes. Sometimes it gradually descends by itself, sometimes it never descends. So the more undescended it is, the higher the risk of cancer. So for example, if it's just palpable at the groin area, then the risk is a little bit higher. If it's completely inside the abdomen, then the risk is significantly higher. And that test is at risk of getting cancer in the future. So it's very important for pediatric surgeons and urological pediatric surgeons. They usually try to descend the testis or remove the testis, if it's not descendable because of the risk.
So if someone's had undescended testes and they've actually been corrected like within 6 months or 12 months, does that negate that risk, or is that risk always still there even if they've been brought down surgically?
Yeah, very good question. The risk is always there. One of the main reasons that you bring it down is that if it becomes a palpable lump, you can pick it up early. Whereas if it's inside the abdomen, you never know, and it grows silently without you ever knowing. So that's why when it's in the abdomen and it's not descendable, they usually remove it because it's not worth having it. For example, intra-abdominal testes, usually the risk can be up to 40 times higher. Whereas if it's in the inguinal area, usually 1 or 2 times higher. So the more undescended it is, the more the risk is, the higher the risk of that testicle getting cancer. And part of it is actually because the testis itself is not a good testis. There's been problems in its formation or organogenesis, and that's why it's more predisposed to get cancer. It's not the fact that it didn't descend. It's the reason why it didn't descend is because probably something was wrong with it in the first place.
Going back to just testicular cancer and looking at patients presenting, how many patients present with advanced disease?
Depends on who you see. So, for example, generally it's not that common. GPs don't see it that often, whereas I'm a urologist who sees a lot of testicular cancer. So a lot of times I get referrals with people with very advanced diseases, sometimes when people have just felt a lump. So it's very variable in which setting you see, like medical oncologists, for example, see it all the time. They get referred to them because it's spread. With urologists, it's kind of half-half. And then in general practice, it's usually GPs see a lot of, lumps. And then out of all of those, maybe some of them only be testicular cancer. A lot of times it's cysts and fluids and other things.
Do you recommend at the first line, so if a patient actually presents with a lump, looking at blood tests and tumour markers, would you recommend just doing tumour markers once it has been confirmed that there's a lump there?
No. So because one of the things about testicular cancer is half of them don't make tumor markers. So the tumor markers we have, unfortunately, they're not very sensitive. We're talking about maybe 50%. A lot of the subtypes of it, for example, choriocarcinomas, for example, make beta-HCG, which is one of the tumor markers. But seminomas, for example, never make tumor markers except for maybe less than 10% of the cases. So, and seminomas are half of the testicular cancer. So teratomas don't make any tumor markers. So we do have some new novel tumor markers that we're working on it. They're called microRNAs, but it's not 100% ready yet for utilization. The sensitivity of those is much, much higher, but it's not available yet sort of as a mainstream. The main thing that we look for is the ultrasound. So whether the tumor markers are normal or not normal, mass inside the testicle is almost always testicular cancer, with the exception of very rare cases. So that ultrasound is the defining things for us to move forward.
Is there any other imaging that is useful for patients with a testicular mass, or is it just ultrasound? Everything else is pretty much second?
Yeah, so sometimes it gets a little bit complicated. So when the testicular mass is less than 1 centimeter, when it is a very tiny little nodule, especially in people who have infertility and all, sometimes they can be benign lesions. Sometimes there could be a subtype of cancers called Sertoli cells or Leydig cells, which are a lot more slow growing. Then there's some cases that people just have little lumps and calcifications and they're not cancer. So sometimes we do MRI of the testis, but it's not a sort of a main thing that we do. The other thing that we usually do is a CT scan of the chest and abdomen, especially if we think that someone has testicular cancer. We want to always stage it to see has it spread anywhere or not. And that's a critical second line investigation for us. So essentially anyone that we see a mass in the testicle, we think about first step to do an orchidectomy, remove the testicle, but at the same time do tumor markers, a CT scan to see has it spread anywhere. And before you remove a testicle, you always want to talk about impact on fertility and maybe sperm bank if you can.
Looking at it from the patient's perspective, is there any common questions or sort of a recurring theme that lots of patients will ask you about when they come to see you about this?
Yeah, well, first thing, like most of the patients we see are young boys, like, 20-year-olds, and it's a big shock to them because, who would think of getting cancer at such a young age? So it's initially is to just help them deal and digest the sort of a news that, they actually do have cancer or most likely cancer. Then the next complexity is usually asking them that you actually need to remove the testicle, and that's a big deal for a young man. And they're obviously scared, usually having surgery for the first time. Having something removed is a big psychological impact for them. It may affect their relationship or, all of that. So there's a lot of different things going in their mind. So usually when you counsel the patients, you have to break it down, do one thing at a time, go through the motions and all. But the good thing is usually testicular cancer is one of the very few cancers that we actually do have very high rates of cure compared to all the other cancers. And the fact that it's actually very fast fast growing is the weakness of the cancer itself, because they're very susceptible to chemotherapy, and you get incredibly good results with chemotherapy even when it's spread. And a lot of times, if it hasn't spread and you just remove the testicle, that's the end of it. Like, you literally move on with your life and you're cured from cancer. So we usually, and all of this has to happen fast because you don't want to wait too long. You have to straight away do the procedures, do lots of scans, tumor markers, blood tests, sperm banking. So it's a bit of a quick and fast journey, and these poor young people, they all have to make big decisions very quickly.
If someone presents with testicular cancer in one testicle, what's the chances the other testicle will get cancer as well?
Yeah, so the risk doubles for the other testicle, but it's scary when you say your risk is doubled now. But if you look back at a big picture, your risk was 1% having testicular cancer, now it's 2% or 3%. So overall it's not that high. So usually when they have testicular cancer and they have treatment, we usually tell them, look, self-examine the other testicle regularly. If you feel a lump, straight away come in and see us. We sometimes do have the option of doing partial orchidectomy if it's a small nodule, just to remove the nodule and leave the rest of the testicle, especially in people who have one testis. But we do have people that we've removed both testicle because both of them got cancer.
Is there any discussion, you've already mentioned it, so I'm sure there is, but referral to fertility services for these patients?
Yeah, so we usually work as a group. We hunt as a pack. So we do have radiation oncologists, medical oncologists, pathologists, radiologists, surgeons. But one of the key factors of the key members of us is fertility specialists. They call them andrologists or different names for them. But they usually are involved in managing patients' endocrine function, make sure the testosterone level is not too low. Discussion about fertility and options in the future, and usually we always like to bank some sperms, so in case whatever happens, you still got some sperm banked up.
Post-operatively, what's the recovery like for patients following the orchidectomy?
Yeah, so orchidectomy is a quick procedure. It takes about an hour or less, and it's a day-stay procedure. Patients go home on the same day. We make a little incision in the groin, not in the scrotum, and we remove the testis and the cord. If the patients want, we can usually put a testicular prosthesis in, which is like a silicone-based, usually prosthesis. We kind of matches the other side, so it looks like that there's two testes in the scrotum. If they want to, we can do it at the same time. If they don't want to and they change their mind later on, you can still do it again. So it's a sort of pretty straightforward procedure. The wound usually heals pretty fast. It's a small incision. The key thing for the patient is to avoid very strenuous activities for about 4 to 6 weeks, because then you'll be predisposed to get a hernia from that incision. That's the same incision you make for hernia surgery.
Wow. I think we've given this topic quite a wide sweep. However, are there any final thoughts or bits of advice you might have for doctors and patients too about testicular surgery?
The most important thing we can say is that early detection. If a testicular cancer is picked up early, it's very straightforward. Half an hour, 1 hour operation, and that's the end of it. You've got a good cure. These things do have some of them are very aggressive and spread very quickly. Some of them are a bit slower, and some of them are much slower. So it's a big range. When it spreads, then the treatment gets very complicated. We talk about chemotherapy or major surgery or radiotherapy. And those things do have bigger impact on the patients, especially young patients getting chemotherapy at a young age or radiotherapy at a young age. And the surgery itself, to have removed all the lymph nodes, is a quite complex case. Sometimes it spreads to chest and other places. So then you need thoracic surgery. So if you can pick it up early and remove it before it spreads, you save so much trouble. So the big advice for the patients, if you feel a lump, straight away see a doctor. And to the doctors, if you see someone comes with testicular lump, urgent ultrasound, chase it up, make sure it's not testicular cancer. And if it's testicular cancer, send it to a urologist. And make sure the patient sees someone. Sometimes, people have got longer waiting lists and all. It's best to just call them and say, I've got this one urgent referral, and we can fast track these things.
One final question. I believe at the beginning of this chat, when talking about some of the causes, one of them just mentioned lightly was injury, sometimes can lead to this. I'm a cricket fan, and every now and then I see a batsman or a batter hit by a cricket ball at 150 kilometres an hour in the region where the testes sit. What would go through your mind if you were seeing that, knowing what you know about testes?
Yeah, look, injury is actually not a big risk factor for testicular cancer. So it's the bigger risk is if you hit the testicle and it gets a big giant hematoma or ruptures and you lose the testicle through the injury itself. So that's a sort of that could be maybe worse than cancer sometimes because you can lose a whole testis just, especially with a cricket ball. So yeah, so those are different things. So if somebody has a major injury, is just straight away go and see someone in emergency, get an ultrasound, see if the testis is intact, if it's ruptured, if it's a big hematoma, we sometimes evacuate it, do a surgery and remove it. But generally, injury itself doesn't cause testicular cancer or doesn't increase the testicular cancer significantly. Not that we know of.
All right, so I can't use that as an excuse not to play cricket at Christmas time.
No, you can play as much as you want, especially during the Ashes season.
Dr. Nari Ahmadi, thank you very much for joining us on This Medical Life.
My pleasure, my pleasure.
Professor Fiona Maclean is a clinical professor in the Department of Clinical Medicine, Faculty of Medicine and Health Sciences at Macquarie University. She's authored more than 100 peer-reviewed papers, as well as 2 chapters of Sternberg's Diagnostic Surgical Pathology and 1 chapter of Histology for Pathologists. Professor Maclean is a previous president of the Australasian division of the International Academy of Pathology, the IAP, with interests in urogenital and musculoskeletal pathology. She also works with artificial intelligence, partnering with Franklin AI. And Fiona's a returning guest on This Medical Life podcast. Fiona, welcome back.
Oh, thank you, and thank you for having me.
Let's start by asking you to define what the most common types of testicular cancer are.
What we see most frequently is what we call germ cell tumours. But then we do have a range of other tumours that we come across, and they're much less common, but they're also significant issues that need to be dealt with. So as pathologists, we're across all of these different sort of entities because we would deal with them in different ways. So we do see in older men in particular lymphomas, in particular diffuse large B-cell lymphomas. We see metastases to the testis, and about 2.5% of tumours that we get in the testis actually represent metastases, usually from the prostate or from the lung. Then there's a supporting cell type that's actually in the seminiferous tubules, which form another tumour type called a sex cord stromal tumour. These are very uncommon, and we've actually been struggling to classify them recently, and I've had a couple of big international meetings over the last couple of years trying to actually help our classification system so that we can help put them in the right box to help clinicians treat them better. And then, of course, in any structure, there's those supporting structures like blood vessels and fat. So you can get sarcomas arising from those mesenchymal structures. And there's a mesothelial lining. So you can actually get mesothelial tumours arising, just like a mesothelioma from the lung can also arise in the testis. So there's actually a very big range of things that can occur. But by far and wide, the most common cancers that we see are germ cell tumours.
What does germ cell tumour mean?
So basically it's a neoplasm that originates from the primordial germ cells or the reproductive cells in the seminiferous tubules of the testis.
So now, does that mean they're previous, like there's the sperm cells or anything like that, or is it from that germination sort of centre?
Yeah, so from the very beginning of those cells. So they actually go through a generational phase. They'll mature into sperm, but they have to start somewhere. So it's where they start from. Those cells can actually go wrong. And then that's where the tumour forms, rather than going through the whole, normal formation of sperm that we would see.
When you look at textbooks, they often split these between seminomas and non-seminomas. What's the kind of difference of this?
Yeah. So, seminomas are actually the most common of the germ cell tumours. So they represent about 50%. And so that's one group. So, there's a pathway, and, we're all into genetics and into molecular and all of that now for all of our classifications. Everything's sort of becoming molecularly based. And there's a pathway with 12p overexpression where you get these, like a precancer, which we call germ cell neoplasia in situ, or GCNIS, and that forms actually in the seminiferous tubules. And there's one whole group of tumours that goes through that pathway. So we always look in the background, and we'll talk in our reports about whether there's GCNIS in the background testis. And seminomas go through that pathway. So they have to go through this germ cell neoplasia in situ, GCNIS pathway, and it's the common precursor for seminomas and actually most of the other non-seminomatous tumours as well. So the mixed germ cell tumours, where you could have a mixture of different types, or some pure tumours. So we get the neoplastic gonocytes, and look now, okay, sperm, what's the role of sperm? It's to make babies, right? And babies have lots of different bits, that you've got to actually have a cell that can differentiate into all different things, right, to make a baby. You don't want a baby that just looks like, one structure. Humans are very, very complex, and we have to have a bit of this and a bit of that, some hair, some ears, some brains, some, epithelium, all different things we have to make up a human. So because of that, these cells actually are what we call totipotent, which means they can go down all different directions because you've got to be able to make all different things, right? So that's where the cell type that it comes from. And we know that about 90% of GCNIS will progress to an overt germ cell tumour in about 7 years. So it does take a long time. And it may even be 20 years. So it could be a very long time that this is sort of sitting there in someone's testis as a preneoplasia. And then it can either form a seminoma, which is, it arises in the gonocytes, or those primordial germ cells that we were talking about that sort of start off all the differentiation, or it can actually form what we call a non-seminomatous group. So as I said, you can have a mixed germ cell tumour, which is a bit of this and a bit of that, which might also include seminoma. Or we break them into 4 main categories. So there's embryonal, which looks like an early embryo down the microscope. So I look at it and it looks very, very early and very poorly differentiated. I've used that word before. It doesn't look very much like a particular cell line. Yolk sac tumour, and we've got I'll talk in a moment about prepubertal and postpubertal as concepts, but the postpubertal yolk sac tumour is the one that's part of this group, and that looks like the embryonic sac or the allantois or mesenchyme down the microscope. Choriocarcinoma, which looks like the cells of the placenta, the trophoblastic cells of the placenta. So these are all parts that you would have to make, to make a baby. You have to have a successful baby. You have to have a placenta, and you have to have, all these parts. So these cells can go into any of these sort of formations, or a teratoma, and again, this is the postpubertal type. And these can form any of the 3 layers that we talk about, the endoderm, mesoderm, and ectoderm. So, when you go back to your early embryology lectures, I remember I had them at 7 o'clock in the morning, and they were not fascinating. And, they would talk about the 3 layers and the different layers and what they formed. Also, a teratoma is part of these, is a cell type that's recapitulating these 3 layers. And it's interesting, people kind of think that ovarian tumours, germ cell tumours, because women can get germ cell tumours of the ovary, right, are the same as testicular germ cell tumours, but they're actually not. They're actually, we're now learning that they're actually quite different, especially some, ones that we've named the same tumour for a number of years actually behave really differently depending on whether it's coming from a male or a female. And now we've got the ability to look back molecularly. We can see that some of them actually have different genetics, even though we've called them the same thing for many, many years. And so, for example, when somebody has a postpubertal teratoma in a man, it's always malignant. But in a woman, it really depends on the differentiation of the tumour, or how mature the tumour is, or immature. So it's not the same between men and women. So you can get any of those 4, you can get all those 4 mixed together, you can get any kind of mixture, that happens to come to pass. So there's a whole, range of kind of, things that we see in that box. And then, as I said, there's that GCNAS big box with the 12P. That's the big main kind of branch that everything comes down. And then there's these less common tumours that don't have these 12P abnormalities. And so they're things like, you would have heard of spermatocytic tumour probably. That used to be called spermatocytic seminoma, and we've renamed it because they actually do really, really well. So we want to pull them out and call them tumour, not seminoma. Teratoma that we call a prepubertal type, which is completely benign. So that is one type of benign teratoma, but it's a special one. And yolk sac tumour prepubertal, which occurs in little boys. And that actually does really, really well. The survival's like 100% for that. So that's actually a great tumour to have if you have to have a testicular if you had to choose one, right?
Yes.
Yeah, and so it's all quite confusing, and each age group has its own sort of pattern of what actually is much more common. And I remember when I was training and we had to do our exams, and we had to do Viva exams, oral exams, and I was having a study break with one of my friends, and we went down to the shops, and we were in the ladies' change rooms singing out over the top of the change room cubicles questions to each other. And so we're singing out, testicular tumour in a 5-year-old, what's the most likely? In this public change room. But, you have to get your study in somewhere, and we needed a break. And so we were doing testicular tumours, whilst trying on clothes.
That is why so many department stores lock their fitting rooms these days.
Or probably have just locked them from me. I don't know.
Now, that is like, even from someone who's studied this area, because I studied this area probably about 10 years ago when I was doing all the AP exams. That seems like it's come a long way from what it was previously. I used to often think, is there almost percentage? Is it almost seminoma and other? Is there a sort of a percentage that you sit there and go, if you know seminomas, 50%, as you mentioned, but is it the other sort of really complex? Is it how do you sort of segregate that?
So 50% for seminoma. Then the most common next category is going to be mixed, non-seminomatous mixed or just mixed. So that group's kind of the next biggest group, which makes up the sort of next biggest percentage. And then all the other things are kind of, all those pure ones that I was talking about, and the sex cord stromal things and all of that, less than 5%. Like that's very small. So really, and so we've actually, as I said, we just spent a couple of big meetings sort of talking about sex cord stromal tumours in great detail. These are things pathologists get excited about. We go and have a conference. I went to Baltimore last year to do one, and I was telling everyone I was going to do balls in Baltimore, and so I turned up to the airport and I was terribly jet lagged, and the guy at the desk goes, "So what are you here for, madam?" And I said, I was a bit flustered, and I went, "Oh, testicles." And this American man at the desk was kind of looking at me, not very happy with me, going, "Madam, would we like to try that again?" And I go, "Oh, sorry, testicle classification." But so yes, we're still working on trying to sort of refine these things. So the things that are very common, they occur commonly. We've got a lot of statistical evidence, and we can be a lot more robust. But our classification's still being further developed in these small categories, which we don't see very often. And it's hard when patients have those, because to give advice then is difficult, and to give treatment recommendations, because we just don't have, if the classification hasn't been completely sorted out yet, then it's really hard to know how they really do behave,
Who typically gets seminomas, and how does it behave?
Yeah, so seminoma is actually a good tumour to have. It's usually, it's males, obviously, testicular seminomas, because you can get them elsewhere. Testicular seminomas, 37 to 41-year-old male is the very typical, age group, but there is a second peak later on in life as well. So we know, the main peak is that sort of earlier peak, but for a pure seminoma, it's sort of in that age group. There are some people that have a predisposition, so people with undescended testes, they actually are predisposed for all types of testicular tumours, but seminoma in particular. So they should be advised to be examining themselves from about 17 onwards. And interestingly, there's some apps you can get, because more young men don't like to have these conversations with their GP. And look, to be honest, my son actually had undescended testes, one of my kids, and I've had a conversation with him, and he's going, "Oh, Mum, I don't want to talk about this. No." And so I just sent him to the app and said, "Look, right, this is between you and your phone. you can work it out what you need to do, but there's a great app called the Ball Checker mobile app. And it's just designed because men don't like to have these conversations, and especially young men, and it's hard, and especially with their mothers or, their GPs if they go, right? So, the Ball Checker mobile app is actually, I think, a really great thing. So I would recommend that to all men because it gives them an idea of what they should be looking for. But yes, back to the point, sort of early middle-aged men, and other things that could make you predisposed are things like Klinefelter syndrome or a family history. And then, these actually behave fairly well. 80% at presentation are clinical stage 1, which means they haven't metastasized. And the 5-year survival is actually quite good. So even at 15 years, it's good. So more than 99% with clinical stage 1 will have disease-free survival at 15 years. The 5-year survival, even with metastatic disease in the good and intermediate groups, is actually quite good too, above 80%. So, it is actually a better one of the ones to have. In contrast, mixed germ cell tumours tend to be a little bit younger. So they're kind of, in their sort of 20s, and they can be more aggressive. So 60% of those will be clinical stage 1 as against 80% for the seminoma, and 1/3 of them will go on to relapse. So the relapse rate is higher. If you had to choose, I would, choose one of those pure ones that I mentioned earlier, the prepubertal teratoma or the prepubertal yolk sac tumour is probably the best ones to have if you had to choose. But of the more common ones, seminoma over, mixed germ cell tumour if you had to pick one.
Are there any features that are concerning on histological examination for seminomas?
Yeah, so we do. We look, we have different ways of categorising these tumours and different ways of actually giving an indication of whether they're in a sort of good or an intermediate or a poor prognosis group. And so we look at the primary size. So for seminoma, that's actually a new thing that's come in, and the most recent classification, of staging system. We do stage now seminomas according to size with a cutoff of 3 centimetres. And we don't do that with the mixed germ cell tumours. It doesn't seem to be such a big discriminator with them, but it is with seminoma. We also look for whether there's rete testis invasion of the stroma there. That's one of the things that portends a worse prognosis, more likely to metastasize, and epididymal involvement as well. The jury's still out on lymphovascular invasion, how much of a risk that is. We do report it, so it's there documented in the report, but we're not sure exactly if it's such a big risk or not at this stage.
So turning to non-seminomatous tumours, how do they behave and present?
Yeah, so as I said, they're more aggressive, so 60% clinical stage 1 and 1/3 will relapse. They have features that we look for. We look for, how I was talking about the different types. We look for a dominant embryonal type. They tend to behave worse. Lymphovascular invasion is actually worse in that group, so we do look for that to sort of predict whether there's going to be metastases outside of the lymph nodes. We look for choriocarcinoma. That's the one that looks like a placenta. So we look for that too. So it'll behave differently, and it'll have a different metastatic route if it's got chorio.
Do you find much use in tumour markers, beta-HCG or anything like that? Is there anything, like if a patient was to present with a testicular tumour, would you say tumour markers? Is there any use in this?
Yeah, no, I rely upon the tumour markers, because what actually happens is sometimes, in pathology, what we do is we get a whole specimen, we might get the whole testis, and we can't look at every single part under the microscope, because if you cut each part of the tumour and made blocks of everything and slides of everything, you'd have so many slides I wouldn't get through any other cases, right, for that day. So I've got to report other people's work as well, right? So we have to sample things. So basically what we do is we take a sampling of the specimens that we get as a representation of what we've looked at. And I personally use the tumour markers to identify if we've missed something. So, if we've missed a component and the tumour markers are high for that particular component, I'll get our trainees, our registrars, to go back and take extra tissue so I can look at it to make sure I haven't missed one of those important things like a choriocarcinoma. So yes, you're right. We look at alpha fetoprotein and AFP and human chorionic gonadotrophin, HCG. And we also look at lactate dehydrogenase, LDH. So they're the three things that we mainly look for. Now, they actually mark for different things. So alpha fetoprotein is a marker of yolk sac tumour. HCG is a marker of choriocarcinoma. It can be raised a little bit. We do actually see it up to 500 international units per litre for, it can be in, say, you can get some cells that look a little bit like placenta cells just hanging around in other tumours. So in seminoma, you might have a small number of these cells. And so it will raise the beta HCG just a bit, like up to sort of 500, that sort of number. And we kind of go, that's all right. But if it's really stonkingly high, I know I've missed a choriocarcinoma component if I haven't got that on my slides. So then I go back. LDH is a bit more non-specific, and you can get false positives with that. So, that's we do it, but it comes with some, caveats. And then more recently, they're looking at circulating tumour markers with microRNA, and I've just co-authored a paper on that recently. So that is coming. It's not really prime time yet, but I think in the next couple of years that'll be something that we're looking for more carefully. And also we'll be looking for that in men that have had treated tumour to see if there's a recurrence.
So is that almost liquid biopsy type stuff?
Yes,
Yeah.
Exactly, yeah, liquid biopsy for the testis.
Yeah. Now, just touching on that, with regards to molecular testing, is that now part of the normal routine of things, or is this still research area?
Yeah, so it's interesting. Different organs seem to have surged ahead more or less with the need for molecular, and some of the other spaces that I work in, we use molecular very regularly. In testis, it's really not part of our normal regime at this stage. The only thing that I've been using it for, and very rarely, is I was talking about those prepubertal teratomas. So they're completely benign. And it's great if you've got one, because if it's identified as that, then you really don't need any follow-up. Like it's out, it's finished. You don't need follow-up after a prepubertal teratoma. And so they haven't gone through that 12P alteration pathway. So they're called prepubertal because, we do think they occur sort of in that sort of spectrum usually. The age group is usually prepubertal, but often they don't present till later. So often it'll be a man of 20 or something like that I'll see this in. Now, the thing is, because they're not malignant, you really don't need to have an orchidectomy. You don't need the whole testis out. So we've had a couple of younger men now with these where it's sort of confined to sort of one part of the testis, and you could potentially then do you would only need to remove part, of the testis. So a couple of the surgeons have done that, in the last couple of years where they've maintained half of the testis, for example, and just taken out the bit with the tumour. So we can do testing for 12P if that's what's suspected. And radiologically, these often look like a cyst. And so they do look a bit different. And so if it's suspected radiologically, then, we could do some testing, confirm that was the diagnosis, and then, treat it sort of conservatively. And then also the man doesn't have to, be locked in for any follow-up or, anything like that, which is important when you're sort of 17-year-old guy, right? You don't really want to be having to come back for, and it's also reassuring that these will not metastasize. So you can tell the 17-year-old that he's not going to be at risk of having something, in the future.
Fiona, do you have any final advice or thoughts about testicular cancer for doctors?
I think just remembering that there are those other options like that ball checker mobile app, I think is great. Like, I think whoever came up with that idea was fabulous, because they understand young men and, who they want to sort of be interacting with and not interacting with, basically. So, putting the health back in their hands, actually literally back in their hands. But that other point that I was making, that testicles are not ovaries, men are not women, and the diseases are different, although there is some overlap. I think this sort of assumption that everything's going to behave the same just because it's arisen from a germ cell is not correct. And I think, we're becoming more and more aware of this now, and I think that does help us understand behaviour of these tumours in a better way. The other thing is, I'm quite excited about the work we've been doing on the sex-cord stromal tumours, and I think that's actually very helpful. Even though they're super rare, they're actually really hard to identify in regards to how they're going to behave. Even a bland tumour, a bland-looking tumour down the microscope can actually behave quite aggressively in that box. And so I think, watch that space, for those sorts of things. I think, generally most people won't come across them, but, just to be aware that there is movement in that space. And if you do have a patient with one of those, being up to date on that would be helpful for them.
My very last question is, you might have seen my jaw drop when you were describing the potential that many of the cells in this area have to become different forms within the human body. I just got a huge sense of wonder at the body. When you're so close to this and needing to get into nitty-gritty for clinical work, does that sense of wonder get lost, or do you people, you specialists, can you maintain that somehow?
Yeah, I think often I do these conferences and consensus meetings overseas, and as I was alluding to, we're just working on some of this right now in regards to classification. And I think it's great. We come together from all around the world with our expertise, and we actually talk about these things and, all these new things that are coming up and how we can actually make things, better and understand them better. But part of that understanding is having a wonder and a sense of wanting to sort of delve deeper, not be satisfied with knowing the sort of, basic what's going on now, but to know really, and in fact, that's why I became a pathologist. It's actually great actually knowing what's wrong, what's wrong with people, right? Actually knowing exactly why this has actually happened and why this person has this thing and how it's going to affect them. As a pathologist, we're the first people to know that. We get the biopsies and we're the first people to see those tumours down the microscope. So I know more straight away about this person and what's going to happen to them than anybody else will know at that time. And it's really good to actually have that knowledge and be able to share that knowledge and help people on their journeys, with in whatever direction it happens to be. By actually having a greater understanding and being able to sort of, help plan and, decide and sort of partner in a sense.
Well, that's why I like having Dr. Travis Brown as a friend and colleague. I want to get that heads up early on, okay? Professor Fiona Maclean, thank you again for joining us here on This Medical Life.
My absolute pleasure. Thank you very much.
Professor Peter Grimison is a medical oncologist at the Chris O'Brien Lifehouse in Sydney. He's a visiting medical officer at the Royal Prince Alfred Hospital and clinical professor at the University of Sydney. Professor Grimison's involved in research including germ cell tumours in testicular cancer, oncology health services including rural oncology, as well as quality of life assessment in clinical trials. Peter's our guest here on This Medical Life podcast. Peter, welcome.
Great to be here. Thanks for having me.
Peter, let's start by asking you to tell us the stages of testicular cancer and what they mean.
The really interesting thing about testicular cancer is we've got stage 1, stage 2 and stage 3, but we don't actually have stage 4 cancer. Most people look at stage 4 cancer as metastatic, advanced and incurable. And even though people with testicular cancer may have metastatic disease, the vast number are curable, so we don't have a stage 4. So the early stage that has not spread beyond the testicle is stage 1. Stage 2 has spread to the lymph nodes within the abdomen. Stage 3 has spread elsewhere in the body, such as the lungs or elsewhere. We'll go on in a bit more detail, talk about risk groups, which people do better or worse, but no stage 4 is a very happy message.
How common is it for patients to present with stage 1, 2 and 3?
Testicular cancer in itself is very rare. 80%, so 4 in 5 people will present with stage 1, and 1 in 5 or 20% will present with advanced disease, whether it be stage 2 or 3.
Now, are there any important features you consider when determining if someone needs chemotherapy or not?
Yeah, so it depends on the situation. Obviously, people who've got metastatic disease, stage 2 or 3, in almost all situations will end up having chemotherapy, but depending on how advanced it is, the level of the tumour markers, if they reach the risk for intermediate or poor risk disease, maybe they've got liver, bone, brain metastases, very high tumour markers, you'll be giving them more chemotherapy, so perhaps 4 cycles of BEP rather than 3 cycles of BEP. There are some limited situations in stage 2 testes cancer where we don't do chemotherapy. In the old days, we did a lot of radiotherapy for stage 2 seminoma, but we have recognised that it is not as effective as chemo and does have a risk of second malignancy, so that's fallen out of favour. There's a resurgence of interest in doing surgery, so primary retroperitoneal lymph node disease for stage 2, to avoid the long-term side effects of chemotherapy, mainly because the side effects of surgery are not as bad as they used to be, using robot techniques, but the cure rates are not as good. And then coming to stage 1 disease, I think the real message for stage 1 is trying to minimise over-treatment. And there's temptation to offer chemotherapy to everyone. After surgery, you could, for seminoma, give a dose of carboplatin to reduce the risk of relapse to about 5%. But in truth, these days, the risk of relapse, even without chemotherapy, for most people is only about 7 or 10%. So you're going to be over-treating 90% of people. It's a little bit more controversial for stage 1 non-seminoma. The low-risk people, no lymphovascular invasion, their risk of recurrence is only 20%. So almost all oncologists around the world will just do surveillance. But if you've got high-risk stage 1 non-seminoma, you've got a 50% risk of relapse. Interestingly, the Europeans will all give chemotherapy in that situation, 1 cycle of BEP. The Americans will not do chemotherapy, they'll just do surveillance, and the Australians are more like the Americans in that situation, because even the 50% who relapse, they can almost always be salvaged later. And the argument of trying to minimise over-treatment, and if 50% of people with high-risk stage 1 non-seminoma never need any chemotherapy, they'll avoid all the long-term side effects.
Peter, I think you've just named that at the end, but I'm putting myself in the shoes of someone as a patient hearing that chemotherapy isn't necessarily being recommended. I would expect my psychology would be, no, I want nuclear. I want to go hard. Have you got any insight into that dynamic and how that message is conveyed?
Yeah, and I think most patients will come in and their parents and partners and think I'm completely mad when I'm not recommending chemotherapy when there's a 50% chance of it coming back. And big picture, I say, well, all the guidelines around the world say it's reasonable not to do chemotherapy. But, if it was any other cancer, it would be different. If you had breast cancer, if you've got a high-risk breast cancer, you've got one chance to cure it, which is now. And if you do chemotherapy, it might improve your chances by 5, 10, 20, 30%. But if you relapse, you'll almost always die. Bowel cancer, the same. But testicular cancer is very special because even if you develop metastatic disease, you're going to almost always be cured later. And, I look at it from the other perspective. The men with stage 1 disease who've chosen to have chemotherapy, some of them have become infertile. Some of them have become hypogonadal and needed to go on long-term testosterone replacement. Some have long-term tinnitus, sensory neuropathy. There's always a small risk of a second malignancy, increased risk of heart disease later in life. So it's not at all straightforward. And exactly as you say, the psychology of everyone, hit it hard, let's do everything. But it's sort of looking at the other side, what are the downsides of chemotherapy? And the important thing, those other cancers like breast or bowel cancer, those chemotherapy have a survival benefit, not just a reduction in relapse. But testes cancer, doing chemo for stage 1 disease does not improve your survival, because you're going to be cured later the second time. So maybe that's the biggest message. It's not going to improve your survival.
You touched on it before where you talked about different regimes or different treatments for like seminoma and non-seminoma. So is there is different regimes for seminoma, non-seminoma and mixed germ cell tumour?
Just focusing on stage 1 disease where we're talking in the adjuvant setting, if it's non-seminoma, if you were going to give adjuvant chemotherapy, it would be 1 cycle of bleomycin, etoposide, cisplatin, so combination BEP. If it was stage 1 seminoma, very sensitive to anything chemoradiation, stage 1 seminoma, you can just give 1 cycle of carboplatin. The technical dose is AUC7. So the chemo for stage 1 is different. The vast majority of people with metastatic disease get the combination chemotherapy, so they get the bleomycin, etoposide, cisplatin, whether it's seminoma or non-seminoma. As we were saying before, depending on their risk group, they're good risks, they'll get 3 cycles. If they're intermediate poor risk, they'll get 4 cycles. If they've got a contraindication to bleomycin, they're aged over 50, smoker, renal dysfunction, we give ifosfamide instead of bleomycin. There's some special situations in stage 2 seminoma. The UK group will give high-dose carboplatin, like carboplatin AUC 10 for 3 or 4 cycles, or just limited involved field radiation and a single dose of carboplatin AUC 7. So there's some special circumstances in stage 2 seminoma that are different, but most advanced will get 3 cycles of BEP.
It must be interesting from not just a doctor's perspective, but a patient's perspective, where they say, well, over in the UK, they give it, but we don't do it here. Does that cause a lot of confusion?
It is very interesting. We have a fantastic research group in Australia, the ANZUP, Australian New Zealand Urogenital Prostate Cancer Trials Group, and we spent literally 4 hours debating on the best treatment for stage 2 testicular cancer. And none of us could agree. And then someone put it into AI, and AI said, oh, it's easy. It's just, we were saying, was it A, B, C, or D? And AI said, it's C, it's fine. You don't need to think anymore. And the truth, people would go with what they're comfortable with. Different people have different levels of evidence. If something's homegrown, they'll go more with it. But I think the truth in oncology, if there's lots of different treatments around the world and everyone seems to be doing pretty well, then the answer is they're probably all fine. So, having a treatment that the treatment centre feels comfortable with, have experience with, know how to manage the side effects is probably the most important, provided there's good evidence behind it.
You have mentioned it, but can you tell us about the common side effects of chemotherapy?
Yeah, so the standard, the BEP, bleomycin, cisplatin, etoposide causes the usual chemotherapy side effects, so tiredness, nausea, hair loss, low blood counts, so risk of febrile neutropenia, thrombocytopenia, anemia, small risk of renal dysfunction, usually not a big problem in our group. I think I said hair loss already. I think the medium-term side effects can be bothersome, including tinnitus and hearing loss, particularly people with baseline problems. For most people, the tinnitus and hearing loss goes away after 12 months, as does sensory neuropathy, but there's a small group where it persists. We're doing a lot of research within ANZUP, a psycho-oncology group called POCOG, the University of Sydney, trying to develop techniques for sensory neuropathy, also techniques for tinnitus and hearing loss. And there's no medical treatment for tinnitus that's effective and safe. There is a drug the paediatricians use, but it may lessen the effect of cisplatin. But ironically, for tinnitus, seeing a psychologist for distraction techniques is probably the best thing. But we're trying to implement that in practice. Some of the very long-term side effects of chemotherapy, 1 in 3 will become infertile. A smaller number, perhaps 1 in 5, will become hypogonadal and need to go on testosterone replacement. So we do need to screen for that. If their libido drops off, if they're fatigued, gaining weight, maybe they need testosterone. And then we mentioned before the 1% risk of second malignancy or increased risk of cardiovascular disease, such as strokes or myocardial infarct. So long-term, don't smoke, healthy weight, watch your cholesterol and blood pressure. All those things are really important.
Are there any targeted therapies that are available for testicular cancer? It sounds like the treatment's pretty effective without it.
The treatment is pretty effective for most. Maybe we'll talk about the small number where it's not. Targeted treatments have been extremely disappointing for testicular cancer. There was a little bit of interest in sunitinib, but it's really minimally effective. Immunotherapy similarly is not effective at all. The latest sort of targeted therapies, antibody drug conjugates. Sometimes testis cancer expresses a protein called B7H3, and there's some phase 1 basket trials that allow patients with testis cancer to do a anti-B7H3 antibody drug conjugate, but we don't have results yet. I think probably the most interesting target is claudin, and there are some anti-claudin antibody drug conjugates in trials showing promising early data, definitely not curative, but really it's chemotherapy, second-line chemotherapy, third-line chemotherapy, maybe fourth-line before you'd move on to those.
How do you actually determine the cycles and duration of therapy?
Yeah, so we touched on that a little bit before, that if you've got good risk metastatic disease, low tumour markers, absence of liver, bone, brain metastases, then you would get 3 cycles of BEP. If you couldn't have the bleomycin, you'd get 4 cycles of everything else. But if you have intermediate or porous disease, rather than 3, you get 4 cycles of BEP. If you can't have the bleomycin, you get ifosfamide instead. So it's based on the risk group.
And how do you measure the treatment goals and patients' progress?
All patients having first-line treatment and second-line treatment will be treated with curative intent. So if they've got good risk disease, their cure expectation is well over 90%, for intermediate, well over 80%, for porous disease, 50 or 60% cure rate. That's even with, liver, bone, brain metastases. And you can monitor them during treatment. Their tumour markers are a very sensitive marker of how they're going. The alpha fetoprotein will fall by half every week. The HCG should fall by half every 48 hours. So you can sort of map out, if your beta HCG is 1 million at the start, it's going to take quite a few half-lives to get to normal, but you can track that on a logarithmic scale and see if they're on track. Sometimes it comes down a bit slower, a little bit worrying. If the markers go up significantly, then that would be a sign to change treatment. Monitoring on radiology is much more tricky. You think cancer gets smaller with chemotherapy, and all the viable germ cell tumours should. But the trick with testicular cancer, there's something called teratoma. It's part of a mixed germ cell tumour, typically slow growing, doesn't respond to chemo, needs to have surgery. So you might have a patient where the markers are falling, which is great, and the scan shows the tumour's getting bigger, and the answer is probably growing teratoma syndrome. So don't panic. If possible, finish the chemo unless there's organ-threatening effects, and at the end of chemo, do resection. And resecting all residual disease in most testicular cancer, particularly non-seminoma, is very critical to remove the teratoma.
Earlier in this chat, I put myself in the shoes of a patient. I want to take that one step further now. What are the common questions that you get from patients?
You do get the... I'm just laughing because, and not in the sense it's funny, but always an unexpected cancer question that the patients are worried where the cancer will come back. And I diligently say, well, it can come back in the lymph nodes, in the abdomen, it can come back in the lung, elsewhere in the body. But most men are worried it's going to come back in the other testicle, and they really don't want to lose both. That's a pretty critical problem, both for body image and for gonadal function. And I reassure men it cannot, almost never can spread to the other testicle, and there's only a 1 in 50 or 2% risk of developing a second cancer in the other testicle. So that's sort of the most common question where my answer is very different to what they're expecting, and that often gives them a lot of reassurance. I think often the men are fairly resilient and don't say too much, but the partners and the mothers often have lots of long-term questions, particularly about survival, particularly about fertility. And one of the joys of treating men with testicular cancer is when they come in with their partners and babies a few years later. And that's clearly a success because they're cured and their gonadal function's very good and they're going to live a long and happy life. So, yeah, I think fertility and long-term outcomes are big concerns.
What are the 5-year survival rates for patients with stage 1, 2 and 3?
Yeah, so for stage 1 disease, the survival rates are better than 99%, which is fantastic. And even if you choose to have surveillance rather than adjuvant chemotherapy, that is the case, so better than 99%. That does rely on good compliance, and you need to turn up for your checkups. If you have a high-risk non-seminoma, 50% chance coming back, you don't do your regular checkups and it comes back and you ignore the symptoms. It could be worse than that, but provided you're compliant, you'll do very well. We did an interesting study recently showing that if it's too hard to do your physical examination because you're busy and you want to do your consults on telehealth, then not doing the physical examination doesn't make a big difference, and provided you do your scans and your blood tests, talk to the doctor. For advanced disease, whether it be stage 2 or 3, we were saying before, if it's good risk, which is most people cure 5-year survival well over 90%, probably about 96%. Intermediate risk disease these days about 85%. Poor risk disease about 60%. So even the group with the poorest outcomes, their cure rate's still better than 60%. But those poor risk patients do need to be treated in high volume centres very aggressively, all the chemotherapy on time, no shortcuts, very aggressive surgery to remove what's left behind, resect the brain mets, the liver mets, the bone mets, the retroperitoneal met, so they may be having multiple surgeries, but if you do things the right way, they do well, most of them.
Are there any signs in or during treatment that are particularly good or bad prognostic signs?
I think what we were talking about before about the rate of tumour markers falling is probably the best, and if they fall according to their half-life, then that's very encouraging. If they fall slowly or the markers start to go up, that's concerning. Obviously, if someone's having severe side effects and can't tolerate the chemotherapy, that's a big problem. There's the temptation to, give more gentle chemotherapy, like doing carboplatin rather than cisplatin, but that's less effective. You can skip some bleomycin doses without doing more of something else. That is less effective as well. But so I think the message, even if you're getting side effects, if at all possible, just push on, just get them through the treatment.
Just finally, Peter, do you have any final thoughts or advice for doctors or patients about testicular cancer?
So it's extremely rare cancer. We still need to do a lot more research. I think the 2 areas of research, one for the vast majority who are going to be cured, is to avoid overtreatment, avoid doing unnecessary chemotherapy or other treatment unless possible, paying attention to the psychological burden, really thinking hard how to manage and minimise those distressing long-term side effects of chemotherapy and surgery. For the small group who have very aggressive disease, again, we need to do better treatments. I'm leading an international trial of accelerating standard BEP chemotherapy for that small group who don't do as well. We've recently completed an international trial looking at the role of high dose versus standard dose chemotherapy in the second line setting. So we've got some big global collaborations that are really important. And then I think the final thing, people do better in high volume centres if they've got advanced disease. So if a patient is in that situation, I think it's very much in their interest to go to a high volume centre because they'll get the appropriate chemotherapy and they'll get that very aggressive surgery that's needed.
Professor Peter Grimison, thank you very much for being part of This Medical Life.
Thanks very much. It's been a pleasure.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.